we're going to be talking about the maternal suicide report, and we're going to hear from Christine Morton and Diana Ramos. Christine is a medical sociologist in the Division of Neonatal and Developmental Medicine in the Pediatrics Department at Stanford. In her role at the California Maternal Quality Care Collaborative, she researches maternal mortality and morbidity in collaborates, excuse me. This was unexpected that I'm talking up here, so I'm talking super fast. But you guys will hear from Christine, and then Diana is a well-recognized national public health expert, a board-certified OBGYN and adjunct assistant clinical professor at the Heck University of Southern California School of Medicine.
It's my pleasure to be here to present the work of a whole team of reviewers and members. You'll see that towards the end of the presentation. But I'm going to be going over the prevalence of maternal suicide relative to other causes of maternal mortality. We're going to learn how often the California Review Committee determined maternal suicide could have been prevented, and also identify strategies for preventing maternal suicide. So really, one of the statements that stuck out from this morning to me was from the Alexis Foundation, and that was helping moms is helping families. You know, and really, if we keep that in the back of our mind when we're hearing all of this data, we're going to realize that we really have an opportunity to help moms going forward. So we'll start with some key definitions first, and that is, this is really important because this is the language that you're going to be hearing all of this data being presented in. And the first one is pregnancy-associated death, and this means a death of a woman while pregnant or within 1 year after end of pregnancy from any cause. So not just because she was pregnant, it's from any cause. The next term is pregnancy-related death, and that is death of a woman while pregnant or within 1 year after end of pregnancy from any cause related to or aggravated by the pregnancy or its management. So this is where pregnancy does come in. And then there's accidental death, which is clear indication that self-harm was not intentional, based on either a series of events leading to death or toxicology reports. And then suicide, which is a death caused by directed injurious behavior with an intent to die as a result of the behavior. So keep those in the back of your mind, and now you're going to have the language for which to interpret the information. So we'll start first with what the California Pregnancy-Associated Maternal Mortality Review is, or PAMR. And PAMR is an activity that many states are striving to establish in their own jurisdictions. And California was one of the early innovators and adopters of the Pregnancy-Associated Mortality Review. And we do this to aim to reduce mortality among pregnant and postpartum women up to 1 year after the end of pregnancy. Now, this is done through deep case reviews. And the case reviews of the maternal deaths are really looking at opportunities to improve causes of death classifications and the timing, determine whether the death was related to pregnancy and the degree of preventability, examine social determinants of health to address health inequity, identify multidisciplinary quality improvement opportunities, as well as produce recommendations for preventing deaths in the perinatal population. Now, as I mentioned, we've been doing this for several years, and in my opinion, this is one of the reasons why California has done so well overall nationally in terms of decreasing our maternal mortality. Because when we started, we actually went through this review and took action and developed toolkits and brought a lot of attention to opportunities for improvement. And you'll see that model followed here at the end. So let's start with some basic overall numbers. So in the US and California, looking at the suicide rate overall among women of reproductive age 15 to 49 years old. And this is looking at data from 1999 to 2016. And you may ask yourself, why is it so broad? Why so many years? Well, because suicide is thankfully not that common, but it is, you need to look at a good number in order to appreciate the trends, and that's why you see that. Now, you can see here that in California, the average rate of suicides was 4.7 per 100,000, but look at the U.S. overall, and that's the top line, and that rate is 7.2 per 100,000 in 2016. You can see that the trend is increasing in the United States, but compared to California, we're more or less, at that steady rate with an average of 4.7 per 100,000 deaths, suicide. So what are some of the causes of the pregnancy-associated mortality in California? Now, these are deaths while pregnant or within 1 year after the end of pregnancy. And this is looking at data from 2002 to 2012. Again, these are not that common, and the events are not that common, and that's the reason why we look at a larger span of time. And you can see here that the 65% of the pregnancy-associated mortality was due to medical causes. But more specifically, if we look at suicide, which is what we're going to be reviewing here, that rate was about 4.3%. So deaths by suicide call attention to an unmet maternal mental health need, so 4.3%. We, as a state, have been very good in conjunction with the California Maternal Care Quality Collaborative and CDPH and several partners throughout the state to address the other medical causes of death. And now it's an opportunity for us to start addressing the suicide rate, the 4.3%. So a moving average of suicide ratios for California women of reproductive age from 2002 to 2012, we can see the top line, that is the non-pregnancy associated. So these are suicides in women who were not pregnant, and then the bottom line is the pregnancy associated. And you can see that overall the trend is about starting out at 1.2 for the pregnancy associated up to 1.8 in 2012, compared to the non-pregnancy associated suicides in women of reproductive age. That is averaging about 5 or so, and that's the top line. But why focus on the pregnancy-associated one? Well, if we think about what happens during prenatal care and postpartum, women are not only seeing the obstetrician, but they're also seeing the pediatrician. We heard earlier from our presentations that the pediatric visits are actually an opportunity to address maternal health. So there's about an average of 20 visits during that first year when a woman is pregnant to postpartum, that there could have been an opportunity for somebody to have done an assessment, an intervention if there was suicide or depression risk factors that were present. So that's why we need to focus on this opportunity. Now, looking at the actual numbers of the cases that were reviewed, we can see that the total number of deaths that were reviewed were 99 deaths by suicide. So how did we come to this number? This number was based upon the death certificates. So initially, 86 suicides were designated on the death certificate as being suicide, and upon review, the committee reviewed them. 85 suicides out of the 86 were identified as truly being suicide. So 99% of the deaths were based on death certificate, were confirmed to be a suicide. Now, the other death certificates that were reviewed were those that were accidental or death due to other causes, and those were 31. When those were more closely reviewed, 14 were identified as being suicide. So if we just looked at the suicide, at the death certificates, we would have missed those 14 suicide deaths. So this really is important to highlight the fact that reviewing the cases, pregnancy-associated maternal reviews are really a critical piece in getting the data more accurate. So an in-depth review process really can give us a more fuller understanding. So now let's start to look at the average of pregnancy-associated ratios for California women by data source. So we talked about the death certificates as being a source for identifying suicides, and that's the bottom line. That's the one that ranges from 0.6 to 0.9. The middle line is one that is highlighting data that is obtained through administrative data. And the top one is the one that is actually the PAMR committee review data. And you can see that the top line, really, the trend is much higher overall when you're looking from 2003 all the way to 2012. Again, highlighting the fact that when you actually review with the team, looking through the details of maternal deaths, you actually get a more fuller understanding of what really happened. Now, what about the suicide ratios among women, California women of reproductive age, by race and ethnicity? We oftentimes hear how there's disparities by race and ethnicity. Well, there are some differences in findings here as well. Hispanic women had the lowest suicide ratio compared with other racial ethnic groups in the perinatal population and the general population of reproductive age women who were not pregnant in the prior year. So Hispanic women have the lowest rate. Now, it's important to remember that really in California, close to 50% of all the births now are to Hispanic women. So if you're looking at the big picture, this could be a good thing, right? But there's an opportunity for improvement in looking at the rest of the population. In the perinatal population, suicide ratios were similar among white, black, and Asian women. However, in the general population, the highest suicide ratio was among white women. Okay, so this is an opportunity for us to pay attention and to really intervene. Now, you may be asking yourself, well, what are some of the reasons for the differences of the racial and ethnic disparities? We're not sure, and we don't know. But I think going forward, together through our interventions, and when Christine highlights some of those recommendations, you may hopefully give us some more insight as well. So now let's look at some more in-depth findings on the suicide cohort. So these are more demographic information on these 99 pregnancies that were reviewed. So we can see here that the age of the women who committed suicide in our cohort were pretty much similar in distribution compared with the California birth cohort. And in general, the women who committed suicide tended to be younger than the women in the non-pregnancy associated cohort. So really there's no big difference compared to the general cohort. In terms of education, again, they were pretty similar, but it's important to note and highlight that approximately 1/4 had a bachelor's degree. So what does that mean? That means that no one is immune from depression, from suicide. Just because you have a higher education, higher education can be protected from some other medical conditions, but not here. So unfortunately, we have to pay attention to everyone, and it's an opportunity for us to focus on everyone. There's no discrimination there. Now, other demographic characteristics, too, to be aware of is that the women who committed suicide were, the majority, 77%, were born in the U.S. They were adolescents at the time of their first birth. And more importantly, they received less than adequate prenatal care during their most recent pregnancy. So again, going to have that prenatal care, having access to a healthcare provider, to a system that hopefully could identify risk factors, that was missing, and that was identified as a difference compared to the California birth cohort. And you can see, too, that approximately half were Medi-Cal recipients, and this was similar to the women in the California birth cohort. Now, in terms of timing of death, so when women did commit suicide, 80% of the suicides occurred more than 42 days after their pregnancy ended. Okay, so this is really important to consider, because when we stop to think about the postpartum visit, if they go, it's 42 days. And if they only had emergency Medi-Cal as their healthcare coverage, it ends during the vaginal delivery, if they had a vaginal delivery, at 42 days. So the majority of these deaths occurred after. So what does that mean? Well, if you don't have health insurance, we really have to start to identify and realize, wow, okay, we need to make sure that that mom is okay, especially if there is a history. We need to make sure that it's the community, the father, everybody who was surrounding that mom is there to help her, because we know from our data and from the study that over 80% of the suicides occurred during that time. So how did it happen? And the gentleman from the Alexis Foundation, this really struck a chord with me when he mentioned, how his wife committed suicide. Well, you can see here, 39% was hanging, then it was drug overdose and firearm. So why even address these? Well, it would be prevention opportunities, but unfortunately, as we heard from his story, when somebody is determined to commit suicide, no matter, how much we try to prevent, unfortunately, the suicide is committed. But for us to know what the opportunities are, if there is a firearm that is present at home, if there is medication, to be able to say, okay, let me put this away, let me get this out of the home, or just really be supporting that patient. Now, in terms of mental health history, so you may be thinking, well, maybe this was the first time that the mom had a mental health issue, and that's why she committed suicide. Well, over 60% of the California pregnancy-associated suicide had some type of mental health condition prior to pregnancy. So what does that mean? That means when we have patients that have a history of mental health issue, we really need to pay attention and to provide that support to them. 25% had new onset mental health conditions. And you can see here the range of the various types of mental health conditions prior to pregnancy. 40% of women had a prior suicide attempt. That's really important. Sometimes in the medical chart, they will indicate that. History of suicide, history of depression, history of suicide attempt. So we really need to be vigilant when we come across that information and we're taking care of those patients. And 67% of those suicides occurred within 6 months of death. So really important to help and be vigilant. Now, the mental health diagnostic impressions were also assessed by the committee. And so what this means is, based upon all of the reviews that were done by the committee, a guesstimate likely clinical diagnosis was made, right? This is a retrospective diagnosis that was assumed to probably have been present. It wasn't a clear diagnosis, but you can see here the range of mental health conditions that were most likely present, and that was depression being the highest one at 56%, substance use disorder at 32%, psychosis at 24%, bipolar, you can read on. But really important to highlight that substance use disorder was present 32% of the time. And many times we start to ask ourselves, is it the fact that the substance use disorder is the way that the mom is trying to help cope with the mental health conditions? Or, they oftentimes are happening concurrently. Now we can actually put these into two buckets. And the two buckets of the mental health diagnostic impressions or the more than likely clinical diagnosis can be put into a psychosis bucket or a mood disorder bucket. So the mood disorder, there were 58%, and the psychosis, there were 26% overall. But again, I want to highlight the fact that 16% of those with psychosis had a substance use disorder diagnosis as a probable diagnosis, and those with a mood disorder, 38% had a concurrent substance use disorder. So less than half of the women with serious mental health condition received psychiatric treatment near the time of their death. This is really important, even though there were probably already pre-existing conditions. This is our opportunity to really intervene to address the issue. Now, what about communication? We heard earlier from today that many times patients are calling out for help. Patients are saying, I don't feel right. This is completely different. Well, we know from our reviews that over half of the women expressed at least one type of suicidal communication. Over half. Wow. And so the suicidal communication was verbalized emotional distress in 62%, and these indicated depression due to financial problems, giving the baby up for adoption or foster care, ending the relationship with the partner. We heard earlier today that that was one of the speakers' experience. There was also suicidal ideation and verbalized a suicide plan. So this is really important to listen to our moms, listen to our patients. In the California Pregnancy Associated cohort, the majority of women had suicidal communications noted within 3 months of death. Okay, so all the women that we reviewed within 3 months, they had talked about suicide. And what about reproductive loss? Well, in looking at the women, there was nearly a quarter of women who had a reproductive loss in their most recent pregnancy. Now, over half of the women in the cohort experienced a pregnancy infant loss or a social reproductive loss, and nearly a quarter had a reproductive loss in their most recent pregnancy. And many times we think, well, it's just a miscarriage and, you know, the patient is okay, it was early on. No, a pregnancy is a pregnancy is a pregnancy. And it's something really important for us to realize and to pay attention, because there's been hormonal changes, there's been emotional connection that has already happened, and we need to really accept all of the pregnancies as a pregnancy, even though it may end up in a miscarriage. And in terms of substance use, you know, I mentioned this earlier, nearly all women with a substance use disorder had an overlapping mental health condition. This is really important for us to pay attention. Again, is it the fact that it's the mental health disorder that is driving the substance use disorder as a way of coping? And sometimes that may be an acceptable way if it's an alcohol use or marijuana use now because it's legal. And you can see here in the numbers that are broken down, 32% had illicit drug or abused prescription opioids with or without alcohol. 7% had heavy alcohol use, and 10% had tobacco or marijuana use only. So women who used illicit drugs or abused prescription opioids were more likely to have experienced physical or sexual violence as children or adults. 54% versus 7%. This goes back to the ACEs. We were talking about this earlier. This is also critical when we're addressing and taking care of our patients, to make sure that we include an ACE screening in there so that we can understand where they are coming from. And it's important to note that over 50% of the women did not use any substance. And in terms of stressors, psychosocial stressors near the time of death, approximately 85% of women who died by suicide while pregnant or within a year of pregnancy had one or more psychosocial stressors documented. And you can see, they range from interpersonal conflicts, substance use, financial hardships, exposure to violence, reproductive loss, death of a loved one, housing issues. So, a lot of these are social determinants of health that we're talking about. So they all go hand in hand, the ACEs, the social determinants of health, the mental health issues, the substance abuse. It starts to all interweave and become one issue of unfortunately, a continuing problem that impacts not only the mom, but the whole family. So the review committee determined that stressful life events precipitated the deaths of at least 65% of women. So to summarize the findings for the data portion, some of the big highlights are that suicide is a complex interplay and outcome of biological, psychosocial, and environmental factors. And by reviewing the cases that the committee reviewed, the big takeaways are pre-existing and new onset mental health conditions are there, and 62% have pre-existing mental health condition, 25% have a new onset, 85% had stressful life events near the time of death, potential coping mechanism, 39% used illicit drugs, abused opioids or alcohol, and 24% of women had a pregnancy loss or had a child removed from them. And there was also 83% a lack of support after pregnancy, because 83% of the women died after the 42 days and up to the 1 year after delivering a baby. So lastly, the California PAMR methods led to a more complete and accurate identification of suicide cases. The death certificate is not enough. Really, by doing the intense case reviews, we actually got more richer data and richer opportunities for us to intervene. So I'm going to turn it over to Christine, who's going to take us to activities on what they can do. Do you want me to read over? Yeah, sure.
You can read this in the report. All of this information that we're showing you today is online at the CDPH MCAH website. It's also available at cmqcc.org website. So don't have to take too many hard notes. I get, I guess, the opportunity to talk about the preventability factors. And as Diana earlier on noted, the really importance of those definitions, we grappled as a committee with how to describe a pregnancy or a suicide to a woman who was pregnant in the year prior. How do we identify that as pregnancy related? What are the criteria that we use? The criteria that we use, and we look at medical deaths, was the pregnancy or its management aggravated? Would the woman have died had she not been pregnant, is kind of another way of putting it, okay? So we have that in the first criteria. Underlying mental health issues were aggravated by pregnancy or its management, right? Women not getting treatment, women not being asked whether they had a prior history, getting the wrong kind of medication, or in the pregnancy just further complicating what was already a fairly complex mental health history, right? And then we added some new criteria because we felt these were really important and unique to pull out. The severe postpartum depression, psychosis, or other conditions unique to pregnancy was something that we found that didn't really fit in criteria 1, but we made that criteria. We added one related to pregnancy loss or neonatal loss because we saw this theme of reproductive loss throughout many of the women's histories. Unwanted pregnancy, and then within 42 days, but we couldn't apply any other criteria. That was usually because we had very little information on that person's case. Sources of information included the coroner's report, birth and death hospitalization records, if they were there. Sometimes we got psychiatric records, often we did not. And with most deaths occurring 42 days or more, how could we make a connection between the pregnancy or its management being related to that suicide? It was really, really tricky and complex. And at the end of the day, although we did look at this and we found that the deaths that were pregnancy related by these categories here. Where's the light? Oh, here it is. Okay, right. So the women of the pregnancy-related deaths, we thought, okay, the suicide was related to the fact that she was pregnant or postpartum. 36% of those were in this first category, severe mental health. So, and among the not pregnancy-related, that was half of the cases. Because this woman, largely these were cases where women had longstanding complex psychiatric histories that predated the pregnancy, and by the time the death occurred, it was unclear what the relationship of the death to the pregnancy was. New onset mental health condition was another really important point that we learned here, that this happens, and 38% of the pregnancy-related cases were in that category. As opposed to just 6% over here. And, for the women for which we had no mental health history at all, it was hard to tell, and we usually erred on the side of not pregnancy related. So when we assess the preventability of these deaths, We wanted to ask, was the death preventable? Could some other feasible set of actions been taken that would have changed the outcome? What was the degree of preventability? We looked at a range of strong, good, some, or none. And what were the alternative actions that we might have taken that could have prevented the outcome? And we call those quality improvement opportunities. The committee, kind of in a philosophical sense and also then in an empirical sense, really decided that suicide at its heart is a preventable cause of death. The half of deaths that were considered strong and good, you saw the intersection of those deaths in the pregnancy-related cases. The pregnancy-related cases were more likely to have been deemed preventable. And the cases where there was some chance to alter outcome were, again, in these medically and mental health, psychologically complicated histories where there had been many efforts, or in the opposite sense, there would have been, there were cases where there seemed to be no support, no care at all. You can see here, for women who had been diagnosed with a severe condition before pregnancy, there was a good to strong preventability in 47% of those. And not quite as high because, again, of the complexity of the case, the histories, and the data that we had. For women who were deemed to have had a mild to moderate mental condition before pregnancy, there was very high preventability. Prior suicide attempt, now there were only 4 of these, and this was the only kind of record that we had of this woman's mental health. But it was prior suicide attempt and no information on anything else. And those, again, were some to none. New onset mental health condition, this is largely where the cases with psychosis was, and we all found those to be extremely preventable. And in the 8 cases where we didn't know, it was kind of half and half. So you can probably come up with these opportunities on your own just from having had a tour, if you like, through this data. But we really looked carefully at a lot of the gaps that came out in the stories we heard today, the lack of intersection between obstetric care and mental health care. And it wasn't always clear in the medical records that we had in pregnancy whether or not that woman had been screened in her prenatal care. And as we saw with the data earlier, the coincidence of substance use, is an important factor to consider when we think about how do we treat moms in labor who may be tested positive for a substance, and which kinds of substances are on the panel, that get tested. And as Diana said, there were several cases of women abusing prescription drugs or alcohol and were completely under the radar in terms of that kind of screening. So the screening has to be, really sensitive to pick up all these various intersections. Pregnancy and postpartum care and support. We don't have a maternity care leave policy in this country. A lot of this had to do with some of them for women who are foreign-born or newly to this country, being very isolated, not knowing any other new moms, not having any connection, and feeling very alone and very apart from support. The fact that we saw this higher likelihood of suicide among Asian women compared to women who give the number of women who give birth who are Asian. We really saw a variety of cases, again, where women were socially and culturally isolated. Some of them in contexts where, male family members accompanied them to prenatal care appointments and things like that. So we had glimpses, we had flashes of insight into these women's lives, but for me, one of the most, one of the very many things that was very hard about looking through these cases was the lack of information that we had about what had happened to them and what their lives were like. The coroner is charged with being able to determine the cause and manner of death. And so if that cause is fairly clear-cut, she was hanging from a tree in the yard, it was a suicide, they don't really capture all the other pieces that go into why did that person, get to that point. And so we have a lot of information. We have a lot more data on these cases than does anybody else in the country, but there's still so much we don't know. We've created the report, and so we have this data, but we're also going to begin to mine that data more to develop manuscripts on particular topics. So if any of you are interested in that, please talk to me afterwards. So we looked at these preventability QIOs, how could we think about how to prevent this? And we decided to use the public health framework for prevention, which lists three levels. The primary levels, which are targeting the general public, right? And within that, there's that selective prevention, targeting individuals or subgroups who have higher risks. And so in that case, you can read all the kind of themes that we found in the committee. The committee members were the ones who identified what these opportunities were. And so we took all of those opportunities and we analyzed them and we came up with these themes. And part of the action that we'll be taking subsequently to this is to say, okay, for these, in terms of this gap between the OB experience and the mental health experience, let's say for Asian women, let's go to Asian mental health services or special organizations that focus on that population. Let's share our data with them and find out what are they doing to sort of to meet that intersection that women often get caught in or lost in. The secondary prevention levels refers to interventions that could have been taken. So this is clearly what we see when women are put on the wrong medication or they're not provided medication or there was an existing diagnosis but it wasn't taken into account when looking at the current condition. It also includes things like referrals and having a comprehensive system for referring women with known risk factors. If a woman was known to have diabetes before pregnancy, there would be a lot of attention to taking care of that diabetes during that special condition of pregnancy. So, for me, that was one of the real aha moments of our data was that these women had signs, they were telling us, and we weren't looking or listening very well. The other piece of it, And so then tertiary prevention includes those interventions right at the clinical kind of level. Here we found, again, a strong need to educate both obstetric and psychiatric providers. Think about how we can provide resources for psychiatric providers. Like there's I think a helpline in Washington State where OB maternity care providers can call in and get advice on the right kind of medication to give to a woman who's pregnant or postpartum. And to think about how are we going to do that? How are we going to fill that gap? So, overall, we really believe these deaths could have been prevented, and over half of them, were like this close. And we identify these themes that are not new to any of you who are practicing in this area, but we've found when we have reviewed and reported the results of deaths of women due to hemorrhage or hypertensive disorders of pregnancy that suddenly this gets attention. Unfortunately, women have to die sometimes for that to happen. But we're in a way fortunate in California that our rates are fairly low compared to the country, and that compared to women of reproductive age, women who have been pregnant or in that past year are less likely to die by suicide. But we still have a problem, and we are California, and you know, for every woman that dies, another 50 to 100 have a really significant challenge, all right? And there's many more. It's like the tip of the iceberg, the canary in the coal mine kind of effect, right? It's a ripple effect. It affects many more people than just the unfortunate ones who die. So we are really committed and focused on moving forward on preventing these deaths going forward, and all of our information is available online. And can't do this work without the volunteer dedication of these people who gave their time and their energy and their resources. We reviewed what was like 117, 120 deaths in a 18-month time period. You know, we met every 2 or 3 months and reviewed these cases, and we made every attempt to get a very well-rounded and diverse set of experts. And I want to thank the 2020 Mom people, because it was a couple years before we did this review. I had a kind of focus group here, and I asked those who showed up, who were psychologists and mental health practitioners, you know, what information would you want to know if you were going to analyze a case of a woman who died from suicide? And on the basis of their answers, we were able to create a data collection template that really captured many more things than we may otherwise have been able to do. So we're always trying to keep this dialogue going between the people who care for women during this time in their life and the data we unfortunately have to collect when things don't turn out well for them, and with the wonderful volunteer labor of these amazing people. And of course, there are those of us who get paid to do it. And we're very grateful now that HRSA and CDC and other national organizations are really focusing on these issues of maternal well-being. And you may contact us. And I don't know if we have time for questions, but
is there any mechanism in the state of California or at the federal level to be collecting this data moving forward?
Very good question. I could talk for an hour or more on the challenges of data collection. I will say, though, that we in PAMR have, from the very beginning when we did our first phase review, it was in 2008, and we were looking at deaths that occurred in 2002. So we've always been about 4 or 5 years behind due to complex, maybe not so complex, but issues of whose data is it, how soon does it get cleaned, what kind of data gets merged, who does that, how does that happen? It's all that kind of process things. But we have been very busy doing a very high-level speed review of all the deaths in California from 2008 to 2016. And so that is just being finalized, and we reviewed them only to find out what was the cause of death and was it pregnancy-related. Okay. And so we're mostly looking at medical deaths there, but we are finding a lot of mental health conditions among those women who die of medical causes too. So, okay, we've got that. It's almost ready to get born to the public. So we'll be up to 2016 on our maternal mortality data, which is within the first 42 days, and it's largely medical deaths. Then we got funding from the CDC to embark on a local project. We'll be doing an in-depth review of all deaths in Southern California counties, still to be determined, but LA, San Bernardino, Riverside, maybe San Diego, we're still kind of navigating all of that. But the CDC wants California's data. We've been collecting data on our own, and meanwhile, the CDC has been drawing from the lessons we've learned and others have learned, and have created a more standardized way for states to do maternal mortality review committees. And so they gave us a little money to help us make that adjustment to collecting data the way they want and adding it to their national data set. And so we will be starting with 2019 data in Southern California. Fingers crossed. Yeah.
Thank you, Christine and Diana. I just want to thank you, and I'm one of those people emailing you for the last 10 years saying, what do we know? And I want to thank you you're kind of the holder of real data, think of it, and I'm so glad the CDC has recognized that.
Yeah.
Because it's all over the place, and we need to really know. So my question that really, I don't know if how much you can describe this, but you talked about prevention and the way you measured it, strong chance of prevention down to little. And given the fact that we know that once somebody has committed suicide, you look at it, died by suicide, you look at it and realize it's a speeding train. Like there's no guilt and no blame about all of those ways you might have prevented. And I know that you've been thoughtful and really careful about looking at that. But given that, I was curious what went into the groups deciding what makes it a strong chance of prevention, or can you talk a little bit about how you measured that?
Yeah, and if any of the committee members are here and Diana's here, I don't know if Lynn is in the room. Well, like I said, there was a clear sort of maybe dividing line between women who had, every case was so complex, and there were only 99, there were 99 of them over a 10-year period. And so when you try to categorize them in certain ways, a lot of different nuance gets lost. But let's take the cases that involve psychosis, for example, because the incidence of psychosis in this study is higher than the national incidence of psychosis, right? So that meant to the psychiatrists and experts on our committee in this field, which I am not, that means there's a higher risk for women with psychosis to die by suicide, and there is effective treatment, and in this case, if this had been done, this woman would not have died. So there were cases like that were pretty clear, or a woman like going to get, and when I've done analyses on these data for the medical deaths too, and we don't ask the committee to necessarily give us opportunities that are doable. Right? We ask them to really let us know. And so some of them were like, longstanding substance use issues. She needs dual care. She needs substance use treatment and mental health treatment. And I've learned that there's not many places where you can get both at the same time. And given the overlap of those issues that you saw in our data, we can say, well, that's a real need for that. So we can say that is an opportunity, but was her death preventable, in the here and now? Kind of no, because we don't have that. So those kind of cases maybe get us some. Diana, please.
I think the word opportunity is the operative word here, because even if we recognize and even if we treat, we can't always predict that that's going to be enough. But I think as a committee, what we were trying to accomplish, at least in terms of the objectives you set out for us, was all things being equal, if we recognized it, if we treated it, could it have been prevented? And was the opportunity there for it to have been prevented? And I think you're right. It's very nuanced and complex, and you can't just kind of say, well, if this, then that, unfortunately.
Yeah. It was much more complex, and I'll also say that another thing that is being discussed on the national level about this is, does it matter, does the designation pregnancy-related matter, or is it really applicable to this category of maternal death? It is when it's hemorrhage, and okay, she wouldn't have bled, she wouldn't have had a hemorrhage if she hadn't been pregnant, and the opportunities are pretty clear on the clinical place what to do, and we know that that's a OB issue, so, we say it's pregnancy related so that OBs will take care of it. But mental health is a lifelong condition, and women are, like Diana said, at these touch points in care. I don't know. We don't know. We're talking about it. Go ahead.
Last question. Go ahead. Laura Clapper from Cigna. Just to comment on what you were just saying, it's interesting because since it happens after 42 days and the people aren't really continuing to see their OB, I could see people arguing, well, what are the OBs going to do? But I guess I would argue that that's part of like a safe discharge from care. If someone's had a risk, there needs to be a safe kind of discharge back to your PCP plan. So, but that wasn't my question. My question was, as we look at these opportunities, do you have data around like how many people had an ER visit within 2 weeks? I know that kind of was sprinkled in even the last talk, but trying to look at, we know people who are at risk, but where's it, the risk and the opportunity combined.
Right.
That's what I was
Right.
trying to understand.
That would be an excellent thing for us to look at as we dive into the data more deeply, and we do have that data.
And it's interesting, it's kind of a similar situation where we know that veterans are committing suicide at a higher rate, right? And I think it's very similar if we looked at it from what I've seen in the literature about like the more combat you've had, if you've had a mental illness before, if you have substance use, all those different things that may be trying to treat their like kind of a primary diagnosis. And to me, we need to look at ways when someone gets care or goes to the ER in particular, because they're probably at a higher acuity, that they're not sent away to come back. That I almost want us to start thinking about the repeat ER visit is like a never event, right? We can't tolerate having people come in to get care and be sent back without a safe discharge and then come back again. Some of these people are coming multiple times and they're still not getting the care they need. So we need to stand up and say never, just like the wrong-sided surgery. Why is this different?
I have no answer for you. We had
No, I mean, we all
had
need to ask ourselves.
We had an emergency medicine physician on our review, and yeah, these issues get talked about a lot.
Because even like so many of the hospital systems are on Epic, we talked about that earlier, greater than 50%. Why couldn't they be flagged in Epic? So when someone comes into the emergency room, they can see that they have a past history, so they know that there's some protocol that they need to see, like a navigator, a licensed clinical social worker, even if it's going into a room and talking to someone on the phone or through virtual care because they're not in the ER, that they would have some kind of mental health evaluation before they leave, right, for a safe discharge from the ER. There's two things I think are important. One is, why is it different in mental health than medical? I don't think it is, right? And why is being discharged from the ER any different than being discharged from the hospital and having to come back? So I think this idea of readmissions that we think about in terms of inpatient care needs to be brought to the ER, because these people are not being admitted, so they get lost in all the research and data and quality that goes on around readmissions. They're repeat visits to the ER, and so somehow we need to raise the focus and the visibility about that.
Yeah, I mean, it brings up a side but related issue, which is that extracting the information we want from the EMR to do these reviews is going to be harder than when our abstractors went out and looked at paper records and could abstract from that, because they're getting, this high stacks of paper because they want to get all this information, how many ED, whatever. And so it's a self-compounding issue that we have to address.
So
Was there one more question? Oh, you.
No,
good,
I was
good.
just going to say one comment on the Epic. So you, as a payer, can actually request Epic to create that flag. And if there's enough payers who are using Epic, whether you're a hospital or your system, create the demand, Epic will respond.
Well, that's all the time we have for this breakout, so thank you so much for joining us, and welcome everyone back into the main room for the continuation of today's forum.
Thank you.